Hi guys, uh, this is Shantanu. I'm here today. I'm here to present my work, Dr. Vidal, at for this year's AMIA Symposium. This work was performed when I was a master's student at the University of Florida. So let's begin. Okay. So let's consider this problem where Nancy is having a fever and she's confused which medication she should take. She has a feature vector with all the important characteristics such as age, blood group, etc. And she has a choice of medication A versus medication B. We can represent this particular problem with this causal graph where X is the feature vector of Nancy, T is the treatment variable, and Y is the desired outcome. And we wish to measure this red path. So the question is how T causally affects Y. The problem is actually fundamentally challenging because at one point of time, we have only the access to one particular outcome. Consider Nancy takes medicine B, which corresponds to T equals to 1, and we only be able to observe the outcome Y1. At that point of time, we won't have the access to the outcome Y0. And we won't be able to measure whether medication B is better than medication A. Here, Y1 is considered to be the factual outcome because we observe this particular outcome, and Y0 is considered to be the counterfactual outcome because we won't be able to observe this particular outcome. We are living in a big data era where we have data coming from all the different sources like the internet, social media. For clinicians, the data is coming from electronic health records, radiology reports, radiology images, chest x-rays from different modalities. So we have, so in short, we have basically lots and lots of data. But in observational data sets, often these confounders and colliders, they can create some sort of biases and some sort of problems. So confounders are those variables, which is the common cause of an exposure and outcome. Colliders, on the other hand, it is the common effect of an exposure and an outcome. And if the machine learning model forgets to model confounders and colliders, then those models are good for prediction, but those models are not causal. Now, causal inference is challenging due to the presence of counterfactuals, as we have already seen in the case of Nancy. There are some ways which handles this particular problem. For example, something called randomized controlled trial, propensity score matching, inverse probability treatment weighting, or EPTW. But often these processes, they have their own sets of problems. For example, randomized controlled trial, they are often considered to be unethical and they are not feasible. And propensity score matching and EPTW, they often use logistic regression to model the particular outcome. And as we all know that logistic regression is linear, so it fails to capture the nonlinear characteristics that lie within the data. We are also living in a deep learning era where, researchers from causal inferences, they actually embrace the different methods from deep learning to model the particular treatment outcome. Here I have given some of my previous papers on this particular aspect. So the idea is to model nonlinear treatment assignment. Deep learning is much better deep learning provides much better ways to handle the high dimensional inputs, and also it provides nonlinear counterfactual predictions. So this is our contribution for this particular paper. We want to incorporate an underlying causal structure to approximate the data generation process. We want to infer the latent variables responsible for generating data using a variational autoencoder. We generate the counterfactual outcomes using a generative adversarial network, or GAN, with variational information-theoretic regularization. We want to estimate the individual treatment effect by minimizing the factual and the counterfactual outcomes both. And also, we try to utilize the doubly robust regularizer for faster convergence. So one of the existing method called GANITE, it is helpful to generate the counterfactual outcomes. So GANITE has two blocks. One is counterfactual block, responsible for generating counterfactual outcomes, and an ITE block for predicting the different outcomes. Now, in the counterfactual block, it has a counterfactual generator, which takes the input covariates x's, t as the treatment indicator, YF as the factual outcome, and a random noise. And together, it aims to predict the factual outcome and the counterfactual outcome, and they are very realistic. But often the prior research shows that instead of sending the true data, can we send the latent codes to the generator to generate the outcomes? Because latent codes are often considered to be the low dimensional compressed version of the inputs. We do that. So how are we going to do that? We're going to see that in our method section. So let's discuss about the problem formulation. So here in this particular paper, we use the potential outcome framework by Rubin. So we are given with a complete tuple where x's are the covariate vectors, t is the treatment assignment variable, y is the factual outcome that we observe. And here we only consider the binary treatment option where t can take the value either 0 and 1. Y0 and Y1 are the potential outcomes for treatment t equals to 0 and t equals to 1. And our goal is to measure the ITE, which is the expected difference of the potential outcomes given the covariate. And we also believe that the strong ignorability assumption holds in this case, which says that the two potential outcomes are conditionally independent of the treatment variable given the covariates. So this is our first contribution. We incorporate a causal graph where we believe that the data or the covariates are generated from 4 independent random variables. They are ZT, ZX, ZYF, and ZYCF for treatment, features, factual, and counterfactual outcomes, respectively. Next, we use a VAE and a GAN together to get or to generate the counterfactual outcomes. Here is the complete architecture of our model. The VAE block tries to infer the latent codes ZX, ZT, ZYF, and ZYCF, and the GAN block takes these latent codes as the input, and it aims to generate the counterfactual outcome. Let's decode this gradually. Okay. So here in the encoder block, we want to infer the 4 latent variables ZX, ZT, and ZYF and ZYCF from the observed covariate vector X. We assume that all the different latent variables, they have a prior Gaussian distribution. Next, we define the variational posteriors using the encoder as a factorized Gaussian distribution. We learn the mean and the standard deviations of each Gaussian distribution using the encoder block of the VAE. And lastly, this is the final elbow loss function that the VAE optimizes. The first term in this loss function is the reconstruction loss, which tries to generate or which tries to reconstruct the data as close as the original data as possible. And this is done by the decoder block of the VAE. And all the KL divergences in the VAE will make sure that the variational posterior should be as close as to their priors. For details of this elbow derivation, please go through our supplementary material indicated in the GitHub link. Once we generate the 4 latent variables, we concatenate them and we name that in big concatenated vector as ZC, and they will serve as the true data for our downstream GAN. So the GAN takes this ZC and a random noise vector as input and aims to generate a complete tuple of factual and counterfactual outcomes, which we're gonna use to predict the ITE. So this is the overall GAN loss function, the adversarial loss function that the GAN tries to minimize. Also, we wanted to make sure that the mutual information between the latent code and the generated outcome by GAN should be maximized. So that is why we want to solve this particular optimization function. However, we know that computing mutual information is intractable problem. So following the InfoGAN formulation, we utilize an auxiliary network Q to estimate this mutual information. The complete loss function by GAN is here. And again, if you wish to see how we actually translate this particular problem to this particular loss function, please go through our supplementary material. Once we learn the counterfactual outcome from GAN, we append that counterfactual outcome to the tuple X, T, and the factual outcome, and we use a downstream Tarnet model to estimate the ITE. And in this Tarnet model, from the 2 potential outcomes, we try to estimate the factual and the counterfactual outcome first, and then we minimize the loss function using both the factual and the counterfactual outcomes. Now here, theta1 and theta0, they are the parameters of the outcome-specific neural networks, and phi denotes the parameters of the shared network of the Tarnet model. Next, we use the doubly robustness formulation by Johnson to ensure faster convergence. So this is the traditional way of estimating the doubly robust, or this is the traditional way of formulating the doubly robust loss, where pi is the propensity network and mu is an auxiliary network. Traditionally, they are all linear. Pi is simply logistic regression aiming to predict the probability of getting treated. And mu is a simple auxiliary network which takes the covariate vectors and the treatment assignment. Here, instead of using the linear regression and the logistic regression, we use a 4-headed neural network. So the first 2 heads, as we have already seen in Tarnet, the first 2 heads are responsible for predicting the potential outcomes. And phi and mu, they are the propensity networks and the auxiliary networks. Here, we first appended the propensity loss to our potential loss that we computed earlier from Tarnet. Then we estimate the doubly robust outcomes. And finally, we compute the doubly robust loss using this way. And finally, we minimize the weighted combination of the potential loss and the doubly robust loss to optimize this particular network. Here, beta is a hyperparameter that we're going to tune in our experiments. So these are the performance metrics that we're going to report in our results. ATT denotes the average treatment on treated. Epsilon ATT means the error on the average treatment on the treated. Epsilon PHE denotes as the error on the precision estimation of heterogeneous treatment effect. Epsilon AT denotes the error on the average treatment effect. R policy, it is the policy risk. Please note that R policy and epsilon ATT will be reported for those data sets where the true counterfactual outcomes won't be available, such as jobs, and for twins and for IHDP, where we have the access to the true counterfactual outcomes, we're going to report the error on PHE and ATE metric. So the first result on the basis of the simulated data from CVE, even though the data generation process of CVE is significantly different from Dr. Vidal with doubly robustness, we can see that our method, Dr. Vidal, with the doubly robust loss performs the best among all the different existing methods. And of course, this is actually indicated by this particular red line. Now, we also generate the simulated data based on our model, and we compare that to the PHE metric with GANITE. Here also, Dr. Vidal with the doubly robust loss performs the best. And we can see that from this red line. We continue the same experiment to measure the log of the PHE error. And as we have already seen, Dr. Vidal with doubly robust loss performs the best, and it is way, way better than the GANITE. For the real world data, we use IHDP, jobs and twins data sets. So first we performed an ablation study and checked that that Dr. Vidal with the doubly robust loss and with the info-GAN regularization performs the best for all the different real-world data sets. We also tried to estimate the marginalized factual outcomes for t equals to 0 and t equals to 1. And in all the data sets, we can see that Dr. Vidal with the doubly robust loss performs better than its non-doubly robustness variant. And we can clearly see that we can clearly see this from this blue bar for jobs, for twins, and for IHDP. And finally, this is the comprehensive comparison of performances in terms of PHE and policy risk of Dr. Vidal with all the other existing models. For IHDP and for jobs, we can see that Dr. Vidal outperforms all the other models. Remember that Dr. Vidal here incorporates the doubly robustness loss and the info-GAN regularizer both. For twins, we can see that Dr. Vidal's performance is pretty comparable with the other models, but for twins, GANITE performs the best. This table compares the performance of Dr. Vidal with the other models in terms of the error in average treatment effect. And here we can see that Dr. Vidal shows pretty comparable performance with the existing model. Finally, in conclusion, in this paper, we incorporated a causal graph to estimate the individual treatment effect. We also utilized a variational autoencoder to infer the latent variables and again to estimate the counterfactual outcomes. Finally, we utilize the doubly robustness to turn it to estimate the ITE for faster convergence. Please refer to our GitHub link for the code. Our model has, of course, some limitations. For example, the causal graph is too simple. In future, we may enforce some stricter disentanglement constraints. instead of variational information maximization, can we use something called a variational information bottleneck layer to measure the mutual information? Instead of TARNet as a downstream model, can we use DragonNet, DCNPD, or the ITE block of GANITE to estimate the individual treatment effect? And finally, we can also use some more realistic data like from News8 or Mimic2 to estimate the ITE and the ATE. So here I would like to thank all my collaborators and my mentors. My collaborators Zheng, my mentors Professor Prosperi, Professor Butler, and Professor Jiang to help me to write this particular paper. And also I'd like to thank NIH for providing the funding for this project. Thank you.